A 25-year-old male presents with chronic knee pain. I am showing you AP and lateral knee radiographs, along with coronal T1 and sagittal T2 fat-saturated magnetic resonance images of the distal femur. Please describe the findings.
The radiographs demonstrate an eccentric, bubbly lytic lesion involving the distal femoral metaphyses and epiphysis, extending directly to the subchondral bone, with no sclerotic margin or internal matrix. The magnetic resonance images confirm endostele scalloping, mild cortical permeation, and multiple internal fluid levels.
What is your primary diagnostic concern?
The findings of an eccentric lytic metaepiphyseal lesion extending to the subchondral bone in a patient with closed growth plates are highly diagnostic of a giant cell tumor of bone, likely with a secondary aneurysmal bone cyst component.
What radiographic feature of this lesion is most useful for excluding a fibroxanthoma or a simple geode?
The absence of a sclerotic border is a key feature of giant cell tumor. Fibroxanthomas and subchondral geodes classically present with a well-defined sclerotic margin.
At what age group does giant cell tumor classically occur, and what is its typical skeletal distribution?
It classically occurs in adults aged 20 to 40 after physeal closure. Over 75% occur at the ends of long bones, most commonly the distal femur, proximal tibia, and distal radius.
Why are fluid levels present on the T2 fat-saturated magnetic resonance images in this case?
Fluid levels are seen in approximately 14% of giant cell tumors. They represent a secondary aneurysmal bone cyst component within the primary tumor, resulting from hemorrhage into cystic spaces.
Why do the solid components of a giant cell tumor sometimes demonstrate low to intermediate signal intensity on T2 weighted magnetic resonance imaging?
The low to intermediate T2 signal is due to abundant collagen deposition, high cellularity, and extensive hemosiderin deposition within the solid tissue components of the tumor.
Where should a biopsy of this lesion be targeted, and why?
The biopsy must be directed specifically at the solid, enhancing components of the lesion. Targeting the cystic or hemorrhagic fluid level areas may yield only blood or fibrous tissue, leading to a non-diagnostic biopsy or a false diagnosis of a simple aneurysmal bone cyst.
Finally, what are your clinical management recommendations?
I recommend referral to an orthopedic oncologist for surgical curettage and PMMA bone cementation. Adjuvant therapy is often used to lower the 10 to 25% recurrence rate.